a couple hundred folks join us, which is great. Do appreciate the time that you're taking out of your day to learn more about vaccine education. The Region 9 Head Start Association has made this our mission in January, February, and now March to continue to bring forward these free webinars for the Head Start community in our effort to really elevate the Head Start community and bring forward your capacity to navigate this space. We'll continue forward in April and in May with 2 more webinars. They've yet to be scheduled, but we do look forward to focusing on some unique populations. In particular, in the month of April, we hope to have a webinar that's really targets for those agencies working in rural settings. So with that, let's get started. We have 3 really wonderful speakers today to continue to share with us from their various perspectives. The first will be Hawaii's Lieutenant Governor, who is also a doctor, Dr. Josh Green. Josh Green is a local physician, husband and father of 2, who has dedicated his life to caring for Hawaii families. Currently, Dr. Green serves as Hawaii's 14th Lieutenant Governor and was elected in 2018. Priorities of his office include addressing the homelessness crisis in Hawaii, healthcare disparities, and a statewide medical staff shortage, also supporting affordable housing. And with the onset of COVID in 2020, he has been leading that state's effort in response. Second, you'll hear from Dr. Thaddeus Juarez, who's a psychiatrist working with one of our grantees in Southern California, Pacific Clinics. He's there supporting their staff and the parents who attend that program. He'll update us on COVID-19 and address hesitancy as he knows it and has been working with populations in Southern California and beyond. And then third, we have Dr. John Molina, who is a Pascua Yaqui and a Yavapai Apache Indian. He is from the Compliance Office of Native Health and works as an urban Indian Health Center affiliate faculty with the University of Arizona College of Public Health. So we have 3 interesting presenters. As Fernando suggested, we ask that you put your questions in the Q&A. We'll be monitoring those, responding in the Q&A or holding them till the end of our presentation and then presenting those questions to the panelists. So with that, I'd like to welcome Dr. Green. Please take it away.
Thank you, everyone. Thank you for including me. You guys are terrific. And I just wanted, before I launch into this, and I'll share a screen in a moment, just wanted to say how much I value Head Start. As I'm a primary care provider, a family doctor, and now I work in the emergency department. So I've seen how challenging life can be for many people. My job as a doctor was with the National Health Service Corps. That's how I first came to Hawaii, to work in Ka'u, where we had extreme poverty, and almost all of my families that I worked with and cared for were well below the poverty limits and just had great need. Most of them also were people of color, the Filipino community and the Hawaiian community. So I watched firsthand the value of Head Start. And I would have one other thing to say, which was, though I wasn't in a low-income family, I was lucky to just be kind of right down the middle class. I was born deaf and didn't have hearing for the first 18 months of life. And so there was a lot of support from healthcare professionals and allied organizations that helped families like my family or other families that we spent time with while I was having surgeries, getting my hearing restored, and getting into a lot of advanced therapy and support as a very little person. So I was lucky. So I appreciate what you do. What you do matters. So let me dive now into COVID, and I'm going to share my screen here in a second. I would say this, the state of Hawaii is having an extraordinary experience like the rest of the world with COVID, and you can see very quickly how the pandemic has affected us as an isolated state, but it is part and parcel of what we've done to try to keep cases down and what we're doing going forward. I won't be shy about it. As a physician, I'm relatively or very pro-vaccination, but I still respect people's decisions, whatever they may be. I will say that having a vaccination program which touched 500,000, here's our headline today, Actually, I'm sorry, I'm sharing my screen, so I'll have to show it. But it's state vaccinations exceed 500,000 in the state of Hawaii. That was today's headline. And you can see what our experience has been. This was from the week of March 7th through the 13th. So very recent. Hawaii's had the lowest numbers of COVID per 100,000 in the country, mostly because we are isolated and we've had good mask wearing and social distancing, but also because our vaccination program has advanced. And it's important because we're trying to keep vulnerable communities safe. Here's the entirety of the COVID pandemic, March 7th, 2000 through March 13th, 2001. Again, Hawaii's had the lowest infection rate per 100,000 people. We've had a total of 28,421 cases. If you adjust for population, we should have had 125,000 cases, so 5 times as many. And now if you look at the deaths in the country, we were second lowest last week. Alaska also fared very well last week. But if you look at the total pandemic, we are lowest in the nation after Vermont and Alaska are 49th and 48th. And this has been something I'm proud of as a physician. Again, we're trying to provide a lot of preventive care for people and primary care. That's why Hawaii tends to do well. We have a lot of primary care because we provide care for everyone in the state. This is our overview, and I'm going to go quickly because I want to respect our time and our other experts, but we wear masks over 90% of the time, and social distancing and hand washing has been emphasized, as has contact tracing. We also opened up a program where you have to test to come into Hawaii, a pre-test within 72 hours, and that's what really saved us. These are our mask wearing numbers. You can see over 90% in all categories except Kauai, which now went up to 91%. I just didn't update the slide last night, but Kauai has had almost no cases through the whole pandemic, but they've been very isolated and it's been difficult on people. Here's probably the most important slide for me to share today. We have 1.4 million people, but now 380,000 of our residents are on Medicaid because there's a lot of poverty and a lot of challenges, and that's up 50,000 individuals since the pandemic began. Also, the mental health impacts, we saw a very large surge in depression and desperation, though we're thankful that we have not seen a surge in suicides in our state. And it's important to recognize how much extra work has been done by good people who may be colleagues of yours, like at NAMI and other domestic violence action centers and so on. I'll share a personal story. There was a tragedy in my building, but not even just in my building, in the apartment next to mine. And we have a really nice building, and I have my wife and kids with me. There was an attempted murder in the apartment next to ours, and a guy who cracked because of COVID. And it was shocking. He's in custody, and the woman lived, thank God, but it was something like we'd never seen. It was right out of a CSI episode, and it was heartbreaking and tragic. And that tells me and should tell you that it's everywhere. The challenges and the crises are everywhere. So as we do well for our people and our patients and our clients, we do well for all sorts of parts of our society. But this other person was living in a fancy apartment right next to mine, and it can happen to anyone. So I wanted to mention that. And then to say that other things have happened. Food insecurity surged 60% in our state. So we have to get to a place where we're safe from a health standpoint and also economic standpoint. Quick comparison, right after the Christmas, New Year holiday, we were at 105 individuals in the hospital. We're now at 25. We had a daily census of 140 cases a day. We're now at 52. And you can see in each of our counties, the numbers have been dropping because we've been safe. And also, this coincides with the start of our vaccination program, which began on the 17th of December. And so yesterday marked 3 months, and we've done 500,000 vaccines in our state. This is what Safe Travels, the program. This is to have the pretest to come in. So that's how we kept the numbers contained. And you can see, though, the difference in Hawaii. And that activity ends up directly reflecting on resources, which ends up adjusting how well we can survive for our most vulnerable people. As you know, if you are wealthy, people always do well, no matter what the crisis is. But when people are struggling, they always really struggle harder. And though this is what our state has looked like, and we've seen the big surge in the summer and the secondary smaller surge over January, we're hoping to end COVID in the next 60 days here. We still saw economic devastation. So we only are at 50% of our economic capacity. And that makes it always hardest to care for and fund programs that are essential to us, like Head Start is one of them. So I wanted to make that point economically. Turning to vaccinations, if I showed you the updated slide, you'd see 504,891 in our state. That doesn't mean anything necessarily in an objective way, except to say that over 20% of our population now is vaccinated, and it'll go up. We're the seventh most efficient state in the country for vaccination programs. We're now into phase 1C, and 1C is 65 and older, and all of our essential workers and people with chronic disease. So here's what 1A looked like. That was healthcare personnel and our kupuna, or elderly. That's our word for the elderly here. That was 50,000 total. Then 1B, we did our elderly over 75, 109,000 individuals, and workers who were front facing, with high potential to catch COVID, followed by, these are our list of essential frontline workers. And you could make a very good argument for other groups, but we were trying to prevent spread and prevent devastating loss of life for our elderly, our most elderly, the grandparents that we need to support our children, honestly. We are now in 1C, which is 65 to 74, and those with other health conditions. And though I shouldn't share it too publicly, we will on the 28th of March move to age 55 to 64. I haven't announced that yet, but I'm happy to share it with you guys. And so there you can see 65 and up again, and it's only taking us 2 weeks to go to the next stage. We also added people on dialysis, people with severe respiratory disease, and people with getting chemotherapy, because the mortality rate for individuals in these categories, or people who are like 85 and up, the mortality rate is about 8,000 times, literally 8,000 times than if you're a teenager and catches COVID. And it's many hundreds of times higher than if you're just a 32-year-old working and healthy without health problems. So we're trying to make sure we don't have any loss of life. We have lost 451 souls, but our projections, had we not taken action, was 4,479 fatalities, 4,479. So we're down about 90%. And now we have very few people in the hospital. Actually, today, I'm waiting for the final number. It looks like we're going to be around 20, 22 statewide in the hospital with COVID. And that number has been dropping off very steeply because we vaccinated our most vulnerable people. I'm going to wrap up in a moment because I'm eager to hear my other friends that are going to present today, but we will make the deadlines and the aspirational goals that have been put out by President Biden and the team. I'm friends with some of those guys on the inside. I get along with all political people because I'm too tired to fight with people politically as a physician on call, but I am happy that we're going to vaccinate people personally. Again, I'm going to be supportive of those who make different choices, because there's a lot of ways to stop COVID, but this happened, in my opinion, to be one of them. And this is coming from a guy who caught COVID, tested positive on 9/11, and was quite sick for a couple of days, and then got vaccinated because I believe in it and I don't want to make my patients sick. In Hawaii, this is how you register. And I just wanted to end by saying thank you. And if you want to hear and see what I do daily with my team, who are just terrific, just do the social media thing with us. It's at LTGov Josh Green, at LTGov Josh Green, or call me on my cell phone or text me. My cell phone is 808-937-0991. That's 808-937-0991. If you just want to, see where we are in Hawaii and talk about ideas to keep people safe. But again, I think that we are going to be able to protect society this way and to get back to normal, or people say new normal, by the summer and early fall. And we will recover really robustly in the coming years. Everything points to that, but we can't take things for granted. And that's the final message I would leave people with. How clear has it become that we're all connected? Whether it's a sick child who ends up in the hospital and their family is devastated and it costs $5 million of healthcare resources and they suffer, or someone catches COVID and spreads it into their community. Either way, we're connected. But we learned it more clearly than ever with an infectious disease that doesn't play favorites based on economics or where one lives or what country they live in. And so I think that this should, if we're smart, unite the world a little bit. And I'll be happy to do my small part to that end. So thank you for having me.
Right. Thank you, Dr. Green, very much. And I've been with you guys before. Thank you for welcoming me again. Unlike Dr. Green, I actually was born into abject poverty. So certainly this is very meaningful to me. I'm not a virologist, of course, I'm a psychiatrist, but every med student, every resident has to start learning things and reporting out to their team, to their residents, to their attendings. And that's been my job the last several months with the agency. I'm also part of the Moderna phase 3 trial, which is quite an education in and of itself. But in the, just for time's sake, I'm going to jump right into this because I'm going to try to come in right under 15 minutes. I talked to Wasi, and I'm going to change my topic slightly because I think I'm going to jump over the 15 months of COVID and jump into where are we today and what is the biggest threat? Well, the biggest threat today is clearly escape variants. Escape variants means this exactly. We hear about the 3 variants, the UK. That's not an escape variant. The 2 escape variants is the South African and the Brazilian. And how do we know that it's a threat? Well, who were the big places in the world when the epidemic started? Wuhan, Italy. Well, what's going on in Italy right now? They've got 15% transmission increase. The escape variants are kind of running rapid over there. They are escaping the vaccine by 61% of the escape variants. There's something called R0, which means, it's a scientific number that means what is the likelihood that one person is going to transmit it, and how many people are they going to transmit to? And you want that number to be under 1. That means things are going down. Well, Italy's at 1.6. So now let's look at the United States. What's going on here? Unfortunately, in the last 2 weeks, 19 states have increased transmission, and 24 states have an R0 greater than 1. 2 weeks ago, there was no state in the United States that had an R0 greater than 1. So what's the problem? So I'm going to have to use some Play-Doh to show you what's going on with the escape variants. So this is the original COVID-19. It's a body, and it has a spike protein we all heard about. On the spike protein, there's this thing called the receptor binding domain. It looks like a landing pad. So this is what the antibodies attack. What most of the world innovative vaccine companies have been able to do is to inject you with an instruction for the spike protein. It has the landing pad, and at that point, this gets expressed in your cells in your body, and now the immune system comes in the form of antibodies. It starts practicing on these spike proteins. Sooner or later, it develops a nice fit. And so one day when you're infected by this real COVID-19, you have the antibodies that attach and disable it. So this is what's happened with the escape variants. This is the South African one, B1351. You can see that its landing pad does not look the same. So I'm going to back up here for a moment and say something. COVID-19 mutates every 2 weeks. So since the inception, there's been about 35 mutations. Only 3 seem to matter with regard to this spike protein, and South African and the Brazilian spike have it, so that our antibodies from the vaccine aren't landing on it as well. They're landing on it about 50 to 60% of the time. That's where we get that number, 50 to 60% effective against the escape variants. So let me share my screen. So here's a coronavirus with the spike protein. It uses it like a key. It goes up, engages your human cell, right? Here's another coronavirus engaging the human cell with the key, goes in, makes a bunch of babies, blows up the cell. So these are the major projection models that matter in this country. MIT, IHME of my medical school, University of Washington, Seattle, USC, the Imperial College of London, CDC just added one in here in the last month or so, but these have been going on for about a year. All of these lines looked like MIT a couple months ago. So on the y-axis, you see daily deaths. So this is where we are currently at about 1,200. All of these other projection models a month ago had us going down to a couple hundred per day. Well, they're all changing now. Imperial College is showing something much different in July, but this is the key one. Los Alamos National Lab, look what it's doing if you extrapolate that. It's suggesting some kind of nasty escape variant wave. This is from the New York Times. I just want to say, what I wanted to say about this is, it didn't have to be this way, and it doesn't have to be this way, right? This is showing you how many deaths per million. These are the top 25 populated countries in the world. It's about 1,600 for the US, Britain, Mexico. Look at these 4 countries down here. Look at how many per million. Most of us would know India has about 1.5 billion people. I don't think all of us know that Nigeria, Bangladesh, Pakistan are in the top 8 countries in the world in population. Look what they've been able to accomplish compared to this. So let's look at what the variants are doing in the United States. The B.1.1 variant is not an escape variant, but it is a problem. It's all over the United States. It's the major one in California and Florida, and we saw what people are doing in Florida last week. So that's going to start spreading here, most likely. Here's the escape variant. Last week, it was only on the East Coast at about 9%, and it was in New Jersey at about 20%, nowhere else. The Brazilian variant is nowhere yet last week. Now let's look what happened in 1 week. All of a sudden, Michigan and Minnesota, or where California is with the B.1.1 variant, but that's not an escape variant. But look what happened here with the escape variant in 1 week. It's already over here. What's this gonna look like in 1 week? It may look like that in 1 week. So here's the problem, the big black cloud. I'm calling it the pandemic perpetuation triad. It's a combination and a synergistic effect of 3 terrible things. 1, this apparently 60% efficacy of the escape variant against the vaccine and/or vaccine hesitancy, of course. Number 2, decreasing social distancing and/or increased mobility across the United States. They kind of work hand in hand. 25 states today are within 10% of pre-COVID mobility levels. So obviously people are feeling more comfortable, maybe less prudent. And lastly, decrease in mask use. Now, Dr. Green had some wonderful stats on Hawaii, but that's not the way it is in the rest of the country. At best, it was 78%. That number is going down. So when these 3 things work together, that is leading us to a escape variant 3rd wave. I'm not going to spend too much time on this, but I did want to show you, this is very complicated, but this is updated data every day of all the major world vaccines. And what it's trying to show you, let's take Moderna as an example. We've all heard the number 95%, 94% against asymptomatic infection. Look what happens to that number when you take it against escape variant. It drops by 23 points. And this goes for all of these, but this table is complicated because it uses asymptomatic versus symptomatic illness. I made it simple. Let's just call it any kind of efficacy versus both. So we take Moderna, the efficacy is 90% against asymptomatic or infection. It drops 25 points against the escape variants to 65%. Same thing goes with Pfizer, and look what happens to Oxford. It goes from 60% to 8%. Against the escape variants. But I think the most illustrative example, frankly, is Novavax, because Novavax is going through the trials right now, and they are a great company. But they're going through the trials with the escape variants. Look what happens to them. They drop 37 points. This looks like what Italy is seeing, 40% efficacy. So I'm going to use the number for the rest of this presentation, 50%. The vaccines are 50% have efficacy against the escape variants. So this is from the New England Journal. This slide data exists for all the vaccines. What it's showing you on the y-axis is the protection against the vaccine protection. What they're showing on the x-axis is the ancestral variant and the escape variant. These are actual human beings in phase 1 trial. That human being there, this is the original COVID strain. When they took their blood and took the antibodies and tested them and all that, this is how good they were. Obviously, we're not going to be able to understand this number. But when they took, now I'm in the trial, they take all kinds of blood from us. I got 10 vials taken from me 2 days ago. And so now they took that blood with antibodies and they tested it against the escape variant. This human being drop from this level to that level, and so on. This all equals about 35, 40%. And this data exists for all the vaccines. So if that's the problem, if this is the problem, if this is the problem, if this is the problem, well, what's the solution? Well, the solution is just the reverse, right? It's the pandemic resolution triad. Regardless of whether it's 50, 60%, let's mass vaccinate against all, even the escape variants, right? Let's prudently social distance and prudently mobilize, not imprudently. And let's not go down from 78%, or Dr. Green's wonderful statistics in Hawaii, let's go up. I think you were at the universal, it's 95%, right? Your numbers were close, right? Let's go up. So you get these things working synergistically. Now we have the opposite of this black cloud. So I'm gonna wrap up here by trying to explain how this works, right? Because it's really kind of hard to understand invisible things. So let's use an allegory how this might work. Imagine that the escape variant is a killer like a vampire. A vampire wants to live, thrive, and propagate and wants to make legions of Draculas. So what do we have against the vampire? Well, we have this. We can mass vaccinate, socially distance, and use our mask, right? But that's not all we have. We have these working for us. The Dracula vampires, there aren't very many of them. They get to live for 3 hours when they're exhaled. They hover in the air for about 3 hours. So they got 3 hours to get to the next house. So we're the next human host house, right? So here's how that looks. Column number 1 here is 4 types of human behavior, which I'll go over. Column 2, 3, 4 is this, resolution triad behavior, right? Column number 5 is what kind of protection they're going to have based on their choices of behavior. In column number 6, I'm going to call the categorical imperative. If you guys remember Immanuel Kant, the categorical imperative means the following. It has a couple different ways to look at it, but I like looking at it the negative way, which is you have a duty not to behave in a way that if your behavior was universalized, it would create an incoherent, impossible, greatly undesirable state of affairs. So now let's take human being number 1. He's chosen to leave his door, his house wide open. He's not vaccinated, he's not wearing a mask, and he's not socially distancing. That vampire is he's got 0% infection. If you universalize that, we have a 100% chance, almost, of an escape variant 3rd wave. Now, human being number 2, he's got 2 doors to his house. He's decided to lock one of the doors. So he's vaccinated and he's given up masking and socially distancing. Well, we went over that it's 50% effective, right? So he's got 50% infection, you universalize that, we got a 50% chance of an escape variant 3rd wave. Human being number 3, this is a really smart person. He's like double bolted all his doors. He's vaccinated, wearing a mask, and he's kind of given up social distancing because he's feeling so confident. Well, he's almost at 100%. He's vaccinated, wearing a mask, and the chance of an escape variant 3rd wave is almost 0. And then you have the golden child. We're going to call this person the socially distanced bank vault with an alarm system. He's doing all 3. That's 100% protection. There's a 0% chance of an escape variant 3rd wave. And I just want to wrap up by showing you this again. It didn't have to be the way it was in America. Besides these countries I showed you, look at Vietnam, look at Thailand, Singapore is just like that. It doesn't have to be this way. And it sure doesn't have to be a big black cloud. Thank you very much. I'll stop sharing.
Oh, okay. Well, thank you, Dr. Green and Dr. Juarez. Those were amazing presentations, very informative. I really appreciate that because it gives us some great insight, at least for me also, into understanding where we're at for the COVID-19. But let me begin, first of all, in my Yaqui greeting. Lyosan Chamniavo, Amana Tabote Bejinewi, John Molina Teak. I just greeted you in my Yaqui language. I am Yaqui Indian from Arizona. The Yaquis are actually a tribe from northern Mexico in Sonora, and my father is full-blooded Yaqui Indian. born and raised in community of Guadalupe, a community here just south of Phoenix. I'm also Yavapai Apache from my mother's side. She was born and raised on the San Carlos Apache Indian Reservation. So I'm very honored to have that ancestry, that bloodline of a people that continue to exist as all indigenous people of Hawaii and North and Central and South America, very proud people that in some ways or another are not unfamiliar with viral diseases. You know, when colonization started and Europeans came over to the New World, the impact on indigenous people was horrendous. Millions of lives that were lost as a result of them being immune naive to a lot of the diseases like measles and smallpox and things of that nature. So COVID is not something unfamiliar to our indigenous people because we've dealt with these types of diseases before. In Arizona, of course, not too long ago, the hantavirus up in the Navajo Nation was rampant. And again, you know, we understand the mechanisms of some of these diseases in Indian country. What I want to do is kind of share some insight from the Native American perspective, and I'd like to speak to, at least from my experience. I'm a retired OBGYN physician. I had the honor of working within the Indian Health Service, both in tribal, urban settings. I also had I'm also a administrator, if you will. I retired my OBGYN practice in 2004 and went to law school with an interest in Indian healthcare law and policy. And so my experience really is pretty wide, over 25 years. I was also CEO for the largest Indian hospital in the lower 48, the Phoenix Indian Medical Center. And also had an opportunity to work with a Medicaid program here in Arizona with the American Indian Health Plan, which provides Medicare coverage for Native Americans here in Arizona. And I'm also on the board of directors for the San Carlos Apache Healthcare Corporation. They took over the management of the healthcare system about 5 years ago. So I've had some interesting experiences, very insightful in working both in the urban population of Phoenix as also in some of the tribal lands. So let me just begin here with to sharing my screen. And thank you all for your patience here. And I see we can do this. And I hope my screen is up there, which I think it is. And I'd like to see if I can move this over, begin our slideshow. And I think we're good to go. Okay, well, I'd like to speak on the topic, the theme of vaccine hesitancy in Native Americans. Overall, Native Americans in our nation experience the highest rates of morbidity and mortality. A lot of these are due to chronic diseases. And I share with people that when COVID made its scene in the United States, I think a lot of our people who lived on the reservations far from urban areas were in some sense protected because not a lot of travel in and out of those communities. So that was sort of an advantage living on the reservation. But as soon as that first COVID opportunity came in, then it was not an opportunity because it spread quite quickly because of the closeness of people living, generations of people under one household. And so those were the things that kind of hit them and caused this huge rise in COVID infections. And as some of you have seen and read, especially among the Navajo Nation, experienced this. Of course, now I want to say that a lot of our tribes here in Arizona have responded really well, much like the experience in Hawaii. And in fact, my homeland reservation, San Carlos, they really kind of geared up, and through contact tracing, through vaccinations, and through all different types of preparedness and the people coming together, they really lowered the infection rates. In fact, we understand now in San Carlos, a population of 17,000 Apache Indians, they've reached a herd immunity of just over 60% of both people that have been vaccinated, as well as people who have had COVID and recovered, and those that have had COVID and got vaccinated. So they're doing extremely well now in our tribal nations. I want to give some historical context to this before I begin, because I think it's important to understand why there might be some evidence of hesitancies among our Native American people. First of all, I just want to put this within a picture to sort of present some themes. That picture on the upper left-hand corner is a line of Apache Indians waiting for their rations on the San Carlos Apache Indian Reservation. At that time, it was a military fort. It was a military fort established by the US government to quell the rebellion of Apache Indians and Yavapai Indians in the Southwest, as was done throughout the nation. As a new world came in, as a colonist came in from Europe, of course, there was a lot of wars and trauma and boarding schools and a lot of history that was very traumatic to Indian people. So from the very beginning, Indian people in general have not really trusted the US government because of this unfortunate history. In this line, you can see the line of people, of Apache Indians waiting for their rations, waiting for rations from the US government. When before there were free people, they would hunt in the desert. So from the very beginning, this type of history really was embedded within not only generations of teaching, but I think even in the epigenetics of our people. Then, of course, medical technology comes in, Western-based medicine and research. And that picture on the right-hand side at the top is a Havasupai relatives blessing blood samples at Arizona State University in preparation to bring them back to their people. This was an unfortunate event of unethical research practices. Researchers at Arizona State University, almost a couple decades ago, went to the Havasupai Nation here in Arizona to say we would like to help your people by researching the problem of diabetes that was rampant among the Havasupai people that lived below the Grand Canyon. The Havasupai people believed this university, knew they had an issue with diabetes, so they allowed the researchers to come in, do research, get blood samples to see what they could find about being able to treat and prevent diabetes. Unfortunately, what happened is the researchers sort of went beyond that and decided to research other things with those blood samples other than diabetes, to research things like schizophrenia, inbreeding, and other issues that they thought were significant. But they never, ever got permission from the Havasupai Nation to do this research. When it came to light of these research practices, of course, the Havasupai Nation was devastated. And as a result, ASU was sued. But what happened is the Havasupai Nation, the elders, the healers went back to get those blood samples, prayed over them, and brought them back to their land. Again, another instance of how much do Native American people can really trust the government? How much can Native Americans trust government-run, funded institutions like universities? Or how much can Native Americans trust anything that is supported and funded by the US government? Again, that historical context. At the bottom left-hand side is a photo of a healing ceremony in my community that I took about 25 years ago. And this kind of goes back to our traditions as Native people around the world, as indigenous people, that before the onset of European conquest, we had our own ways of healing, of treatment, of taking care of ourselves, which was a holistic way, which combined the use of natural herbs and medicine, which combined ceremonies, which combined spirituality. And as a physician, I still very much believe in these concepts, because for me, it's just not health as being a sort of an absence of disease, but rather health as being a state of wellness and balance. And these concepts were very much ingrained within our people and are still very much utilized. A study that was done up at an urban Indian clinic in Chicago found that at least 80% of Native American people living in the urban area of Chicago still sought the recommendations and treatment of traditional healers. Traditional healers still exist, both on rural reservations areas as well as in the urban areas. And these people would always seek the counsel, the advice, or the treatment of healers before they would go to Western medicine. Again, looking at the historical contact, and again, because they felt comfortable going to a healer that understood their ways or spoke their language. I went to medical school. I was one of the late bloomers into medical school. And before that, I was a crisis counselor, a mental health counselor working in my community. But my reason for going to medical school was to come back to my community of 5,000 people, of Yaqui Indian people, to open up a clinic. And the reason I wanted to open up this clinic, because when I was visit my people in my community and saw them sick and dying at home, the reasons that they wouldn't seek healthcare was because, one, either they didn't have insurance, two, they didn't speak English very well, or three, they just didn't trust the Western medical profession. That inspired me to go to medical school and become a physician and come back to my community. And I opened up a clinic, which we ran for almost 20 years, very successful, because it was a community clinic here in Guadalupe that our people trusted and trusted the providers that worked there. And we integrated a lot of practices and their belief systems into healthcare. On the right-hand side at the bottom is a photo, of course, of what we see as Western medicine. When we talk about physicians and surgeons, and we talk about hospitals and things of that nature, we see it in the context of the person with a white coat and the stethoscope. We see it in the form of the scalpel. We see it in the form of pill bottles. We see it in the form of electronic health records. This is the Western base of, so the Western concept of medicine that is pretty much ubiquitous, and is understood that this is the way healthcare is practiced. Well, with that background, I want to sort of go into some considerations to vaccine hesitancy among Native American people. First of all, I again, like what Dr. Green mentioned, I think healthcare and what we want done to our bodies, what we want injected or what we want cut out, is really a personal choice based on meaningful informed consent. It's really a medical legal sort of concept that patients have a right to decide what they want done to their body. Sometimes it's difficult for physicians to accept that, because in some ways medicine has become very paternalistic, that we think as physicians, as a medical profession, we tend to know what is right for you and what you should do for yourself. But we have to remember, that our bodies as traditional people, we believe is sacred. We were given life and the choice to make decisions for our own person. So again, I'm not advocating for or against the vaccine, but to understand that people do have the personal choice. But then there's a lot of medical social pressure that can be influenced, and this is coming through media, this is coming through news report. There's a pressure for us to get vaccinated, and I can understand that, because this is a very devastating disease that we need to get control of. In fact, I just got word last night that my aunt of 82 years old passed away from COVID. She lives in Buffalo, New York. 2 days later, her husband of 55 years passed away as a result of COVID. It's real, it's out there. And I think people need to get really informed, even our Native American people, of what are the risks and benefits, because when people make choices about their healthcare, it's really about risk and benefits. And as we as physicians understand, that's what we talk about when we're going to treat somebody. Let's talk about the risk and benefits. Educational level has been the other factor. Came out in January by the University of Southern California in a study that showed that people with a college education were twice as likely as compared to no college education people to get the vaccine. And again, I think that kind of makes sense, that people who are educated understand. Dr. Juarez did a wonderful presentation and showing us the mechanics of how this works. And I think from a science, Western science-based perspective, it makes sense to people who are educated, who can understand the language, who can understand the dynamics of physiology and biology, that says, yeah, that makes a lot of sense. Let's do it. Our Native American people have the lowest rates of college education. This is due to poverty. I myself grew up in poverty. My parents were both migrant farm workers. I used to work in the farm fields from Arizona up to California, picking every fruit you can think of. My first memories of 4 or 5 years old was sitting in a field of radishes, literacy to a level that they can understand.
Dr. Molina, this is Ed. It looks
You
like
know, I
you're,
love
there you go.
the visuals. Am I back on?
You're back on. Yeah, sorry.
Oh, okay. Okay, sorry. Okay, so again, just going back to educational level, bring it down to their level so they can understand, use pictures, use anything to be able to bring it to their understanding of why vaccination could be important for them. Assimilated versus traditional. Among our Native American people, over 570 tribes across the nation and Hawaii. There's some of us that are well educated, have assimilated to the Western lifestyle, yet there's other people who are traditional that still believe in the old ways, still practice the old ways. So much differences in the way they look at the world. So we have to take those into consideration. My proposition is that people who are more assimilated in the Western way of lifestyle are probably more likely to want to get the vaccination, as opposed to those who are traditional and believe in the old ways and the old ways of healing and understanding. Even in some traditional people, like my Yaqui people, believe that when you get a disease, you were meant to get the disease, and that disease means something, and the disease is trying to tell you something, and the disease is only trying to make you stronger in mind, body, and spirit. So very vastly different ways of looking at the disease processes. Good to understand, what does my patient think about it? You know, when I was in practice and seeing our people, I would always ask them, how do you think you got sick? Why do you think you got sick? And how do you think you're going to be healed? Because again, traditional Native people, indigenous people may look at things a little bit differently. Sorry, I'm just having problems here. The other thing that is very strong among our people is really about relationships, very close with kinship systems. So the experiences of the vaccine and COVID is related to the experiences of family members. So they really look to family members as to how they saw their disease and what happened. And if it's a negative experience, they might be more hesitant to get the vaccine. Accessibility, what I call the social influences of health, systemic barriers that prevent them from getting tested, prevent them from getting the vaccine, geographical differences. Even here in the urban areas, transportation can be very difficult in a city of over 3 million people. Social media has been a great influence. A lot of our people are on social media because they like to keep contact with their families, but there's a lot of things on social media that come up that makes them hesitate. Things like they read that the vaccine, COVID-19, I heard someone say that it's a mark of the beast. It's the 666. They say that there's certain things, devices and implants that they put into the vaccine. There's that, again, that historical mistrust and misunderstanding of what's out there. People saying this was done too quickly. They don't know what's going to happen. How is this going to impact people 3 or 5 years from now? All this stuff on social media, where most of our people get their information from, because most of them already have a cell phone. And finally, just to close out, trust is really the linchpin. There was an article that came up from the National Council of Biotechnology Information through the NIH that talked about Native Americans when it comes down to severe diseases, and they talked about this in relationship to cancer. Trust is the most important thing to help people get the care that they needed. Trust in the system, the hospital, or trust in the providers. Many times, you know, we're trying to get more Native American young people to get into health professions because we believe that our people would trust their people. If their provider is Native, there's a higher level of trust. Finally, let me get to my last slide here. This is my last slide here. Just to close out, this is a picture of my relatives up in San Carlos, but as co-op Cherokee Chief Wilma Mankiller. Her doctor did not know how to heal an illness, only how to cut it out. More so herself, she added, he, the doctor, did not know my clan, my family, my history. How could the doctor know how to heal me? It's all about establishing relationships, and there's many ways to establish these relationships in Native American communities, but that's what's important, to develop trust. With that, Chokesia, thank you very much to my relatives, the people out there. That's a photo of me and my wife and my daughter at a powwow. We take part in ceremony, and then the right picture on the teepee is us in Sundance ceremony up in South Dakota. And with that, I'll thank you, and good blessings to all my relatives and people out in the audience. Thank you.
Thank you, Dr. Molina. And first and foremost, our condolences for the loss of your family. It's always a tragedy, and it's been expressed in the Q&A as well. Each of you spoke about mental health from different perspectives. I heard Dr. Green talk about the mental health and its fragility in a closed setting. Dr. Juarez talked about mental health and the resistance of choice. And Dr. Molina, you spoke about mental health as well as we look toward trust and the providers of the information. When you reflect on where this pandemic is and where it's likely to go in the next 60 days, what would you say are the one or two, maybe three things, and I'll ask Dr. Green to start, that people should be most mindful in this space of mental health? We know the physical health, we've got some of that down. Obviously, we're challenged, but where should we be pushing ourselves in the mental health space?
Well, thank you for asking that. I would say from a mental health standpoint, it's about isolation. Isolation has been very dangerous for people, and it's isolation of our elderly because if they live in long-term care facilities or alone, they've been asked to separate because of the risks. And so that isolation is very difficult. Plus just families being apart for so long, that isolation leads often to depression and other even more serious challenges with mental health. So I think we should be mindful of that. I actually think that as a nation, we've suffered to a degree of post-traumatic stress disorder as a result of this pandemic, and it will be important that we recognize that as we come out of it.
Thank you. Dr. Juarez, your thoughts on this?
I definitely agree with everything Dr. Green said. The only thing what I would add to it then is that as we approach the isolation and the needs that the populations have, the stigma then gets in there, because there's so many more people now that would have never thought about availing themselves of mental health now, right? But because of what Dr. Green said, there's a whole lot more people that, and so we as doctors and health workers have to deal with the stigmas they're dealing with that wasn't an issue before. So, I mean, it's just, I think, an issue of empathy and how to open up those conversations. So,
I think among our Native American people, I think what's really helped us, and because I agree, I think the sense of isolation and the unknown, I think it kind of marginalizes people in how they react and how they're doing to COVID. But what I've seen happen on the reservation in the urban income community is to develop this sense of community, a sense of community, they're all working on this together, you know, a sense of community where we kind of share each other's concern. Healthcare providers and institutions can become more involved in being able to connect people together, you know, give them information, provide them means of support where they can go to. And certainly at the one-to-one level, where people either getting vaccinated or they're getting tested, or these are opportunities where healthcare providers can engage in developing a more meaningful relationship that goes beyond just the provision of healthcare.
We have in our chat a couple questions on social media. I'm curious to hear from the three of you. How have you seen it effectively used during this time in your communities? And what are some of the examples of uses that you might raise up or suggest for Head Start programs as they are working to both reduce hesitancy among staff and also inform families?
I'll start from, I would probably, what I've seen that seems to be working well. Well, let me go back to Molina's comments just for a moment, though, because I do think those small conversations just between any kind of health worker and patients can make a huge difference. People that were adamant against it, if you take the time with them. So contrasting that to answer the second question, I tend to agree with what Bill Gates says in all of his 20 years of work in Africa, that you find the influencer, right? Somebody that, so what Bill Gates would say, it's certain villages, and there's somebody really important in that village. So certainly the same thing can happen in social media to a gigantic extent, even if it's the Kardashians or whoever. If people can relate to them and they're spreading the message like that, it's probably, Bill Gates thinks it's the most powerful tool, and I can't imagine disagreeing with him.
No, I agree. I think within the Native American community, again, especially in the rural areas, this technology, social media, has really been impactful. Of course, there's been some negative consequences to it, but the positive side is people are able to communicate with each other, to share information, especially when among tribal members who may not understand as well. Sometimes the sharing of information might be in their language, or the sharing of information can be translated from respected elders in the community. That's the kind of influence it can have, because again, like I said, I would say like 90% of people on the reservation have access to social media.
I've had that experience. I think that's correct. I think it always is best to be able to communicate with someone you know. That's super valuable. Interestingly, social media has created a village concept for some societies. In Hawaii, people say it's the coconut wireless, where we communicate with each other through our clans, and we always know someone that's just 1 or 2 degrees of separation apart from one another. But social media has been impactful for at least my team. I can only say that I had very minimal reach to people before the pandemic. About 2,000 people in our social media circle. We jumped up to about 100,000 over the course of just a few months, just by doing a 1-minute little update, 1 minute on a whiteboard, giving people numbers, trusting them to decide for themselves what they felt was relevant. And it was extraordinarily effective. So now I can communicate if we are going to launch a new clinic. We start a free clinic when people lost their insurance, people went to it, or there's a vaccination pod that we're going to make available to people. It's really easy to communicate and it's free. So that's been a great thing to experience. I still love telling people in small groups what I believe, but the larger social media footprint is powerful.
Thank you. I want to be sure to respect your time. We're right at the top of our hour. So first, let me thank Dr. Green, Dr. Juarez, and Dr. Molina. Thank you for the wisdom you shared, the time you took, the care for our community that you've expressed. And of course, we welcome you back at any time as your work progresses. We look forward to hearing the lessons that you're learning as you work with various communities. I also want to be sure to thank the board members who helped put this together today for Region 9. Cedric Andra from Family Support Services of West Hawaii, Amy Corbu with First Things First in Arizona, and Wasi Tesfa from Pacific Clinics in Los Angeles, and who's also the chair of the Region 9 Head Start Association. As you see on the slide there, we do post this webinar recording in about 24 to 48 hours up on YouTube, where we also have our January and February presentations. So you're welcome to go there and share those as it fits your needs. And then again, we'll be back in April. Hopefully we'll be addressing other aspects of vaccine education and continuing to update us on COVID. As we learned clearly from Dr. Juarez, we're not out of this yet. We still have a long ways to go, and we need to continue to be mindful of our habits of masking, hand washing, and social distancing. So we'll continue to visit the topics as it fits. So have a great afternoon. Thanks certainly for being with us, and thanks doctors for your time. Thank you, Fernando, for your support on the call, and have a good afternoon, everyone.